Every year, tens of thousands of lives are lost to suicide in the U.S. It's a staggering and deeply troubling reality.
He really is.
And despite, focused efforts, the numbers unfortunately just keep climbing.
Hmm.
So today we're doing a deep dive into a critical document that explores some innovative approaches to suicide prevention. And it shines a light on an often overlooked resource, the everyday community member.
That's right, the non-clinical person.
Exactly. Our mission here is to unpack how empowering these individuals, the sources call them gatekeepers, how that can fundamentally transform our system of care.
Yeah, how they fit in.
We'll explore the surprising insights uncovered by a recent project trying to, well, bridge this very gap. Consider your shortcut to getting up to speed on this vital and evolving field.
Okay.
So let's first confront the sobering reality our sources lay out, the current landscape of suicide in the U.S.
It's pretty stark.
It really is. A devastating social challenge affecting people of all ages, genders, races, socioeconomic backgrounds. I mean, did you know it's the second leading cause of death for those aged 10 to 34?
Yeah, and fourth for the 35 to 54 group. The sheer scale is immense. And suicide rates increased a sobering 31% just between 2001 and 2017. That's despite various national and local prevention efforts.
31%. Wow.
But here's a critical point, one that really challenges a lot of assumptions. The CDC reported that 54%, over half of those who died by suicide, had no recognized mental health condition.
54%. That's huge.
It is. It strongly suggests our current methods for surveillance, protection, and prevention are, well, significantly falling short. They're missing a huge portion of those at risk.
That 54% figure, yeah, indicating no recognized condition, it really makes you rethink our standard approach, doesn't it?
Absolutely.
It highlights this vast, unaddressed gap where the clinical system just isn't reaching everyone.
Yeah.
And the economic toll, I mean, it's just staggering, too.
Still, definitely.
A single suicide cost over $1.3 million back in 2013, mostly from lost productivity.
Right, the ripple effects.
And the total national cost. It exceeded $93 billion that year. That's more than the annual spending of almost every single state.
And if you connect that to the bigger picture, data from places like Oregon really underscores the urgency.
Right. Oregon's numbers were quite high in the source material.
They were. Oregonians are nearly 8 times more likely to die by suicide than be killed by another person. Think about that.
8 times.
Yeah. The state saw suicides climb from 545 back in 1998 to 908 in 2019. In some years, it even surpassed deaths from strokes and influenza. It's a crisis that demands new perspectives.
And it's not just adults, is it? The youth data was particularly heartbreaking.
Terribly so. Emergency department visits for mental health conditions by kids under 18, they jumped 92% between 2007 and 2015.
92%.
And admissions for attempted suicide went up 79%. And this is shocking. 43.1% of those were children aged 5 to 10.
5 to 10 years old, that's almost unbelievable.
It's deeply concerning. And in Oregon, the stats showed nearly 1 in 5 8th and 11th graders seriously considered suicide.
1 in 5.
And 1 in 10 8th graders actually attempted it in just one school year, 2017-18.
So this raises a really important question then. If the clinical system isn't always the first point of contact, or maybe not even a point of contact, and so many people aren't identified with mental health conditions, where does that leave us?
Well, exactly. The sources we're looking at strongly suggest we have to look beyond purely traditional clinical responses. We need to broaden our scope considerably.
Okay, so given these critical gaps in traditional care, where do the sources suggest we look next?
They really highlight this underdeveloped but potentially essential resource, the non-clinical layperson, someone acting as a, quote, gatekeeper.
A gatekeeper. Okay, what exactly does that mean in this context?
So a gatekeeper, as defined in these documents, is basically someone who identifies risk and performs rescue and supportive behaviors. They're essentially closing the gate to the act of suicide and opening the gate to hope and healing.
I like that framing. Closing one gate, opening another.
Exactly. And this role becomes critical because a person in crisis is often incredibly vulnerable. They might be struggling with intense stigma or feelings of what the researchers call thwarted belongingness, like feeling totally alone.
Right, disconnected.
Or perceived burdensomeness, where they genuinely believe they're just a burden to others.
Which must make it so hard to ask for help.
Precisely. These feelings make it incredibly difficult for them to help themselves. So in these moments, an ordinary person, a layperson, can truly become, and this is another quote, a chief interventionist by proxy.
Chief interventionist by proxy. That's a really powerful idea.
It is.
But the sources also flag a potential issue, right? Well, basic gatekeeper training like QPR, which stands for question, persuade, refer.
A really vital first step.
Yeah, absolutely vital. It's
Mhm.
evidence-based, it's effective for that initial knowledge boost, but often it's just lecture-based and maybe falls a bit short.
That's what the research suggests. It provides short-term improvement, but it often needs more. Many trained gatekeepers still feel unprepared or unsupported afterwards.
And that could be dangerous, couldn't it? They risk becoming a second victim themselves if they're not properly equipped for what might be, a long-term supportive role.
That's a real concern. And what's crucial to recognize here is the context. Traditional providers, agencies, they're stretched incredibly thin.
Right, capacity issues everywhere.
Exactly. And emergency departments are often, frankly, ill-equipped for mental health crises. There was one really poignant quote in our material from someone who actually sought help in a crisis.
Oh yeah, what did they say?
They said, "What I learned about going to the hospital when I was having a mental health crisis was never to go back."
Wow, that says so much, doesn't it?
It really does. And it dramatically underscores why the non-clinician, the gatekeeper, becomes such a critical link in this whole chain of care.
Okay, so this brings us to the core goal of the specific project we're looking at today.
Hmm.
They wanted to address this gap, right?
Yes, exactly. By exploring supplemental education and support for these gatekeepers. The idea was to see if they could become, full partners with mental health professionals in a more comprehensive system.
Makes sense. So how did they go about trying to better prepare these gatekeepers, moving beyond just the basic training?
Well, the project aimed to implement a pretty innovative approach, using something called the World Cafe method for collaborative learning.
The World Cafe method. Okay, tell us about that. Is it like a workshop?
Sort of, but it's specifically not lecture-based. It's much more interactive. It's a facilitated group discussion where participants actively share and discuss their experiences, drawing on their own knowledge and, importantly, peer knowledge.
So learning from each other.
Precisely. Studies have shown it's really good at fostering connectedness, empowerment, and peer support. It really respects stakeholder participation and sharing, which, can be much more effective than just a one-way lecture, especially for a role that someone might find themselves in for a lifetime.
And the sources mentioned this connects to Bandura's theory of self-efficacy.
Hmm.
How does that fit in? Why is this collaborative approach potentially more effective?
Right, good point. Self-efficacy, according to Bandura, is more than just basic confidence. It's a person's judgment of their capability to organize knowledge and successfully transform it into practice.
Okay, so it's about believing you can actually do it, not just knowing what to do.
Exactly. And that belief isn't just built through acquiring knowledge, it's also built by observing role models, by practicing skills, and critically for this method through the socializing aspect of interpersonal interactions.
The social learning part.
Yes. So the World Cafe method was chosen specifically to provide that crucial social component. The aim was to improve the participants' perceived self-efficacy in actually applying those rescue behaviors they learned about.
Got it. So the research question for this specific project was pretty focused then.
Very specific, it was. Does a focused roundtable discussion using the World Cafe method among non-clinical laypersons who have had gatekeeper training and interact with persons at risk for suicide improve their perceived self-efficacy in preventing suicide?
Okay, and then things didn't quite go according to the original plan, did they?
No, they definitely did not. Life intervened, as it often does. The project was originally planned as a face-to-face World Cafe, aiming for about 20 participants, measuring their self-efficacy before and after the session.
Standard sort of study design.
Right. But then, as you can probably guess, the COVID-19 pandemic hit.
Right. Changed everything for everyone.
It really did. The project team had to pivot, quickly shifting from the planned in-person event to a virtual format using Zoom.
Okay, so they adapted.
They did. But as a consequence, the participant group ended up being much smaller, just 7 individuals.
Only 7. That must have impacted the numbers.
Significantly. It meant the quantitative data, the measured changes in self-efficacy scores, weren't statistically reliable. The group was just too small for that.
Okay, so the original research question couldn't really be answered definitively.
Not in a statistical sense, no. However, and this is where it gets really interesting, this unforeseen shift led to a very rich gap analysis.
Like gap analysis.
Yeah, basically the discussions they did have, even with the small group, ended up identifying some profound barriers and also enhancers within the existing suicide prevention system. And they got some unique insights into virtual engagement, too.
So even with just 7 people, the qualitative data, the discussion notes, verbal reports, I think they even mentioned doodles.
Yes, even doodles. That qualitative stuff revealed some really powerful insights.
And what was the most common theme? You mentioned resources earlier.
That was it. By far, the most frequently used word during these discussions was resources.
Interesting. What did that highlight?
It really highlights a critical systemic issue. These gatekeepers, they're eager to help, they want to help, but they constantly face fragmented, incomplete, or just plain hard-to-access resources.
So the information isn't easy to find or use.
Exactly. Participants reported there was, quote, no centralized compendium of resources and information. They desperately needed specifics. What community services are actually available? Where are they? Who do I contact? What exactly does this facility provide?
Yeah, practical stuff.
And crucially, is care immediate or is there a 6-week wait? Things like that. This demonstrates a huge barrier to their ability to effectively do the refer part of QPR.
That's a massive point. It's not just about knowing what to do in the moment, but knowing where to reliably send someone afterwards. And knowing the path isn't just another dead end or a long wait list.
Precisely. A bad referral can be devastating.
And the discussions also pointed to maybe a deeper issue around how the whole system of care operates, didn't they?
Absolutely. The system was often perceived as not being very person-centric or trauma-informed.
Trauma-informed.
Yeah.
Can you unpack that slightly?
Sure. Trauma-informed principles basically mean approaching care with a real understanding of how past trauma can impact a person's behavior, their needs, and how they respond to support. It's about creating safety and trust.
Got it. And the participants felt the system wasn't always doing that.
That was the perception. One participant noted how frustrating and potentially harmful it is to be asked, who is your significant support person, especially if you don't have one. That can just worsen feelings of aloneness.
Yeah, I can see that.
Another really impactful anecdote shared was the sense that, quote, some of the care is impersonal and not warm or welcoming. More grandmas, not just clinicians.
More grandmas.
Yeah.
That paints a picture. A call for more warmth, maybe.
Exactly. A call for empathy and human connection. And it led to this idea that all staff, not just the designated mental health professionals, should really be trained as gatekeepers and definitely in trauma-informed principles.
That makes a lot of sense. What about the virtual format itself? Did they learn anything specific about doing this kind of discussion online?
Yeah, that was interesting too. There were definitely both benefits and barriers reported.
Like what?
Well, some participants actually found the virtual platform, being in the comfort of their own home, offered an ease of connecting diverse community members. People could join who might not have been able to otherwise.
Right, accessibility.
And some felt a greater sense of safety, even saying they were more comfortable sharing because of the level of anonymity that sometimes comes with being online.
Okay, so some positives, but barriers too.
Yes. Others felt that not seeing faces or the limitations of the virtual interaction kind of hindered that feeling of connectedness. It wasn't quite the same as being in a room together for everyone.
So a mixed bag.
Pretty much. It suggests that while virtual engagement can be really powerful, think about the logistics, no childcare needed, no travel time.
Huge benefits there.
Right. But it also means the facilitators need to be highly skilled in managing the online etiquette, setting expectations, and really working to build that connection despite the screen.
That's a key takeaway for anyone doing this kind of work now. I also loved that detail about the doodles in the notes. What did those reveal?
It's a great little detail, isn't it? It shows how different ways of expressing things can reveal underlying thoughts. Some doodles apparently hinted at concepts like powerlessness, that feeling gatekeepers might have, or the idea that a referral, that R in QPR, might not always be to a clinical professional. Sometimes the best referral might be to a safe person, like, say, a trusted school custodian or a coach, someone who provides that immediate human connection.
That really broadens the idea of what a resource can be, doesn't it? It's not just formal services.
Exactly. It's about the network of support.
So wrapping this up, what does this all mean for you, the listener? This deep dive really shows us that preventing suicide seems to require a truly comprehensive, community-wide approach.
Yeah, it's not just about hiring more clinicians, as important as they are.
Right. It seems to be about empowering every single one of us, recognizing that we can all potentially be a gatekeeper. There's unique power in our everyday connections.
And this project's findings, even though they shifted, they didn't just highlight a lack of knowledge among gatekeepers. They really illuminated a lack of structural empowerment.
Structural empowerment, meaning the system needs to support them better.
Precisely. It confirmed that while gatekeepers want to act, things like fragmented resources, ongoing stigma, and sometimes a care system that lacks that emotional competence or warmth, these are significant hurdles. The documents really emphasize that the layperson gatekeeper is an invaluable partner. Their lived experiences must be honored in policy development and how services are actually implemented.
It feels like a really powerful shift in thinking, moving away from a purely top-down, expert-driven model towards something more ground-up, more community-centered. This project, even with its pandemic pivot, it vividly demonstrates the value of including the layperson as a full partner, not just in delivering interventions, but in understanding the problem and co-creating solutions that actually work in the real world.
Yeah, solutions that resonate with lived experience. And as the research points out, suicide rates, certainly in Oregon where this was focused, they continue to climb. That urges us towards innovative interventions, not just simply more of the same.
By doing things differently, not just doing more.
Exactly. And what if the most effective solution isn't solely about what professionals do, but about fully recognizing, supporting, and empowering that whole network of everyday people who are already out there trying to help?
It really makes you think, doesn't it?
Yeah.
About the power of connection, the power of knowledge, often in unexpected places. So maybe a final thought for everyone listening.
Yeah.
What small everyday action could you take this week to perhaps be a better gatekeeper in your own community? Maybe it's simply starting a conversation with someone who seems down. Or maybe it's taking 5 minutes to learn more about the actual support resources available right there in your local area.
Small steps can make a big difference.
They really can.